first of all, I think I probably just want to just do a few little check things with you. So we've got this protocol, and it's still quite malleable and things like that. So we brought up lots of questions and things. So we maybe won't get the answers right now, but I hope it felt generally pretty good. I suppose we have some questions. That Lucas Thumper device, really, that's a thing I'm not sure how soon or how late to put on. At the moment, it's on third cycle. We worked out it takes about 20 seconds to put on if you practice a bit, which is quite good. So I'm proposing that we still keep it at about the third cycle. Does anybody think we should be doing it sooner, later? Any views, or is that
I think that's a reasonable thing, because it's not only putting it on, but if you are successful, you need to carry out the procedure. That means we have to take it out again. And that's kind of, I think if you leave it to third cycle, at least you have tried everything and you're almost now looking at a long procedure with long CPR. So I think that's when you need to commit yourself to that.
And most of the times it's an acute event that you can correct within the first 3 to 4 minutes.
That's right. Yes.
So if you bring it out early in the cycle, then that kind of interferes. So bring it out later.
My second question is that in my REACT protocol, I've got in asystole, I've got do some massage until you can put the external pacing on and getting it going. But I'm thinking that really, we probably don't need to do that, do we? We can probably shock straight, we can probably put the, I'm thinking maybe we should swap this, and maybe we don't need to do a little bit of CPR. The reason I put that there is I thought it would take ages to put the external pacing on and people would have low knowledge of it. But what do we think about CPR and then pacing versus pacing first? Do you think we can do it pretty quickly?
Well, again, it depends on what the scenario is. If they already have a pads on connected to the machine, then we would go and start it straight away. If not,
most of the patients do come with the cath lab.
Yes,
Sometimes that's in cath lab normally. All the patients.
You just take the 2 minutes off. You just do it until we've got.
Yeah, what we do is CPR and get the pacing as soon as you can.
Yeah, I think you need to do a swap it.
And so most people would have pads on, would you say? Pacing, So we definitely need to have no massage until after 3 shocks and no massage until after that. So that's really good. That'll be quicker. That's fantastic. Thank you. This is good. This is.
Well, I wouldn't say no massage, but
So yeah, till after.
Try and get it as soon as, but in the meantime,
try the pacing. If that fails, then you're on to 2 minutes of massage, doing the circle every 2 minutes. Great. So the next thing I'm a little bit we should change is the adrenaline, amiodarone, and Lucas all on at the third cycle. That's a lot of things to be suddenly doing, and we're a little bit violating all guidelines if we give adrenaline at 6 minutes, because it says 3 to 5 minutes. All the guidelines say give it after the second cycle.
Yeah, so I think adrenaline should still be a bit upfront, because there may not be much evidence, but we do see that from time to time when you give adrenaline, it will give you the blood pressure and enough time to get the other things going.
Yeah, so the guidelines do actually say adrenaline after the second cycle. So perhaps we should give adrenaline after the second cycle, and then it's amiodarone and Lucas on the third cycle. I think we should change that. Agreed? I think that then puts us in line with all Resus Council guidelines. So I was originally thinking that maybe that should be pushed far into the distance so we can try and fix them, but actually, you can do your 3 shocks, you can do 1 cycle, you do a shock, okay, failed, right, give adrenaline. Let's go around, do another shock, okay, failed again, amiodarone and Lucas. So it separates up what drugs you're giving. I think
it's also not, there's no point giving adrenaline unless you have a CPR and the cycle after it, because it's not going to go anywhere. So wherever you put it, it has to be after, if you're going to give adrenaline, then it needs to be CPR for 2 minutes. Because the drug won't go anywhere literally without CPR.
So the guidelines say after second cycle, you've tried your second shock, failed, you're doing some massage, that's when that's going to go in. Okay, yeah, that's pretty good. That's looking nice. So atropine. So does anyone have any strong views about whether we should add atropine to this or whether we should leave it out? Because it's not in international guidelines. When you guys go on ALS courses, they don't say give atropine in asystole.
We do use it on very
we use it on a very regular basis.
Standard practice almost.
Yeah,
But
in
for
and
heart
arrest.
arrest.
So this is arrest.
We do low heart
So
rate.
bradycardia we do, but not for
This is
heart
not
block.
bradycardia, this is arrest.
It's
Arrest.
Asystolic arrest.
Asystolic arrest.
It's-
You're allowed to use it with a blood pressure.
It's out of the guidelines for asystolic arrest now.
Yeah, I think
Yeah.
we should not.
I
It
don't think
depends,
we
it
should.
depends on the context, Joe, really, because if you think about what Madha say, when the pump is failing, when edema is the key, furosemide is not there, but furosemide will be a good drug to get out of jail in his setting. And atropine might be a good one to consider when heart rate is drifting down to 40 to 35, and that might be the pathway that you have to perhaps get you out of jail.
So,
a
so
few
it's still
times.
in the non-arrest one.
I don't
It's
think
just
it will be
the
indicated
arrest
in the
one.
arrest situation, but in the non-arrest situation, it might be get out of jail card.
Yeah,
like
I think
this one.
for asystole, I think atropine is.
I don't think it has a role in
Yeah.
assistance as well.
Yeah.
Okay,
we don't-
good. So we'll leave that off. That's
Yeah.
good because that keeps it clean, doesn't it? So that's really nice. I guess one little thing we've maybe missed out here is some kind of reminding. This is meant to be our H's and T's for us. We don't have anaphylaxis on that, and actually it's not an H or a T. No, we
No.
I didn't realise that. So
It's A, it's A.
it's kind of a toxin. Yeah, it's under a T a bit.
It's a big hat, HAT.
You can
No, it's a- it's anaphylaxis.
But we don't like the H's and T's anyway. But
you
I was
can make
thinking
it
of
like a hyperallergic or something.
yeah. So
It's
well,
A.
this is just we don't invent the H's and T's. All the research councillors have been doing it for years. So the Americans have 7 H's and 7 T's. We've only got 4 of each.
Hyperallergic.
But I was thinking maybe we should add. Consider anaphylaxis in an arrest. Now, if you actually think what you're going to do in an anaphylactic arrest, it's actually IV adrenaline. So, because it's not IM for arrest, it's only IM if you've got a pulse. So you're still going to give your adrenaline anyway, but you're actually thinking of it and getting rid of whatever it is. And also, it might remind you, if it is anaphylaxis, don't do another screening shot to do another angio, because maybe it's the contrast that's causing anaphylaxis.
So in the anaesthetic college, we do a lot of anaphylaxis work, and we've removed hydrocortisone and Finnegan from the
Just adrenaline.
just adrenaline. And also all so-called anaphylaxis should have ICU involvement. That is because the long effect of anaphylaxis is they can have it 2-3 hours down the line. The reason why they remove hydrocortisone is that people think it does something. And then the second thing is that Finnegan makes people unconscious. So we've just removed it. Now we only give adrenaline, and it just depends on if the patient's conscious, you give it IM, and if you are experienced, you can give it IV, but it hurts. But if they're unconscious, we would give boluses of IV adrenaline and then start an adrenaline infusion.
Yeah. And that's a very good point. This is just the arrest bit.
Sure.
So just an arrest, I'm just conscious we've kind of left out an anaphylaxis in an arrest, although there isn't a whole heap you do in an arrest that's that much different, but a little bit, which is just the don't give extra angio contrast if it's the angio contrast that might be doing it. So I'm thinking of adding it in there, but there's not a whole heap different we're going to do with anaphylaxis in an arrest. So in the not arrest, just like you're talking about, that's, we can downplay a little bit hydrocortisone and the Finnegan, but I think that's, so I can't think of anything else too different to change this to. That was lots of good changes, that's good, we don't want everything to change, so that's good. So and then hopefully we'll find from your evaluation forms, or send me an email, what you thought about every single different little section and things. And then the e-learning is just meant to sort of back that all up, really. So to me, it felt like an okay pace of the day. We could maybe have done a few more quickfire scenarios in the morning, but that's us just sort of getting the feel of it. But anyone to say?
Yeah, just I think your tachycardia protocol, you mentioned like adenosine 3 milligrams.
Mm-hmm.
I think that's kind of too low dose to use. We normally start at 6 and go up higher. So
Yeah.
I think it's my thing, but it's something that we may change.
We could.
The other thing I thought of
6,
was,
yeah.
so we give a lot of blood thinners and all those things. We sometimes forget of the brain intracranial bleeds and those things.
Yeah.
I mean, we do see sometimes strokes in the recovery and those things. So I don't know. I think
Yeah, I've got a CVA flip chart.
One is thinking out of the box now.
Yeah, so we didn't do a CVA scenario. I did have a CVA on the flip charts, but it didn't seem to find its way into that little flip chart lecture, did it? Because, yeah, we do absolutely have a CVA one. So here's a question. You know, if someone strokes out down in your recovery, big stroke out, so what are you going to do? Do you ever have abilities to get clot out of the brain here? Do you have a acute stroke team?
Yeah, code stroke.
We call it code stroke.
Not yet anyway. I mean, they're talking about bringing interventional, neurosurgical or radiology team, but probably in the next 12, 18 months.
And what do code strokes do? What will they do for you?
Auckland, I mean, it had to be in 6 hours and they send it up to Auckland.
So do CT start away and then
so there's a
will come and see, and if there's no bleed, then they will consider.
Yeah, so bleed with a coil and then
thrombolysis.
clot.
If they can, yeah.
And, so you can do cerebral thrombolysis here.
Yeah.
yes, yes.
So maybe we probably do need to. It is somewhere. We need to have that for tomorrow. There is a CVA flip chart, but maybe we should probably certainly practice a recovery scenario of a stroke.
I once had
quite useful.
I was fortunate enough to have a stroke, not me, but during the day. It was a day case, patient stroked, and Zach was available. And we laced up and got the patient up, and he pulled out stuff, and the patient recovered. So that was good.
And you went to a different lab because you got a special vascular.
There's a lab upstairs, yeah.
Yeah. That's the future.
So we talked about that. This is many years ago, but that service is not involved.
Lots of people say that cardiologists should get involved. You know, you guys, you just
We talked about
pick one up.
that, we stopped shit for calls.
Especially the
Yeah.
registrars have got the tendency to go up north.
Anyway,
Very good at production.
you've done that plenty.
CT brain. Cerebral angiograms are perfect.
Well,
Dual training interventional neurology.
Well, I think we'll then call it to a day. I think I do want to say some massive thank yous. We certainly should say a massive thank you to Rob, who's come here, especially done all the simulations. And definitely say a massive thank you to your team. So we've got Janine, who's been amazing, and Lee there, and we had Karen and Bruce, I think it was, not here today, who set everything up as well. And then obviously a big well done to Nada from Bruce here as well. So I think that finishes it. So from me, Joel Dunning, thank you very much.
Thanks to Joel, and it's been a pleasure working with him and his team in the UK when we met last year. It was fantastic. He amazes me. He doesn't behave like a surgeon, does he? Actually a surgeon.
That's why they've sent me here.
Thanks, Joel, for making that trip.
He's too smart to be a surgeon.
Maybe that's it, yeah.
I'm not getting involved in that.
Thank you very much all. Thanks for coming. Enjoy your Saturday.